Good afternoon, everyone. Thank you for joining us. This is our, I can't even remember which number in a series of our RHC series of webinars. And so we're joined with Amy Graham with Stroudwater, and she is really the revenue cycle management go-to person. And so today she's going to be touching on some of those revenue cycle management tips and best practices, and in particular coding best practices. And so, as I mentioned earlier, this is a smaller group, and so you have controls over if you want to unmute yourselves, or if you want to put a question in the chat, please do so. We want these to be as interactive and as informative as possible. And so please, if you have questions or ideas or comments, please feel free to blurt those out. And with that said, Amy, I will turn it over to you.
Hey, thanks, Laura. I appreciate it. And I will say to everybody, she says that I'm the go-to for all things revenue cycle. And I share with people, I really enjoy talking about revenue cycle. And today's topic, we may really be in the weeds because it's RHC coding best practices, but it's really talking about the basics about billing and what you need to do for getting your RHC claims out. And I'll be honest with you, this is a different bird from what you're expecting with other revenue cycle items that are out there. So again, use the chat box. Feel free to interrupt me or send me a note afterwards, just letting me know that your head is exploding. And after you've had a chance to go through this, here are all the questions you have, because I'll be honest with you, it does. You're going to listen to me. You're going to be like, what in the world is she saying? And I try and make it as clear as possible. But just giving you that heads up ahead of time. It's like, if this were an exercise class, this might be a hard one that you would thumbs down on because of the information that we're covering. So I'm just going to start out easy though, and just talk about what an RHC is. And so an RHC is a CMS designation. So it's a rural health center. It's a designation that CMS put out there. And they've done this so that services can be provided, primary care services can be provided in underserved areas. And it helps those people living in those areas have access to primary care. And all state Medicaids are required to recognize an RHC. But commercial payers, they make no distinction for an RHC. So that's where it really gets icky when we get into some of these later slides, because everything I tell you, it's going to relate to Medicaid and Medicare, but not commercial payers, or it could be this payer, but not that payer. In an RHC, it's a team approach. So you have physicians, MDs and DOs, you have mid-levels, clinical psychologists, or dietitians and diabetic educators, which are considered incident to in an RHC. At least 51% of the services must be primary care services. Just as an aside, that pediatrics are actually considered primary care services in an RHC setting. 50% of the time, the clinic must be staffed with mid-levels, and Medicare reimburses the services at an all-inclusive rate, an AIR. Each provider who is in the RHC must have their own NPI number, which is a National Provider Indicator. So this is one of those things that I think is really fascinating about an RHC, is that an RHC visit can take place in the RHC itself, at the patient's residence, which would include assisted living facilities. It can occur, an RHC visit can happen in a Medicare covered Part A skilled nursing facility and at the scene of an accident. So you actually can have an accident that happens, and one of your providers goes out to perform services at that scene of an accident, and the visit can take place there. And so I think that that's really unique and a cool thing about RHCs. When looking at them, when you talk about the reimbursement, I said before that Medicare reimburses a flat, all-inclusive rate for RHC services. And it would be really neat if Medicare just said, hey, bill me one number and we'll be good, but you still have to bill for those services. And we'll get into that here in a minute. The payment limit is based on national statutory limits. So you have a calendar year 2022, the payment, that all-inclusive rate, is going to be $113. Now, there may be some RHCs that if your RHC has been around for a while, then that payment limit may be grandfathered and calculated at a different rate based on the cost report. But those are only for those grandfathered RHCs. And so if your rural health clinic is relatively new or been established in, say, the past year, your payment rate for all the RHC services is $113. Medicare Part B deductible and coinsurance rate apply, so that once the patients meet their Part B deductible, Medicare pays 80% of the AIR and the patient pays the remaining 20%. For certain preventative services like an annual wellness visit and the initial preventative physical exam, the IPPE, Medicare will pay the full AIR and patients don't have a copay. So those same rules apply for the deductible and copay, but the calculation is based on the all-inclusive rate and not the individual charges for services. And non-RHC services, though, are paid on an allowed amount for the service. So with that all-inclusive rate, your RHC will only get $113 in 2022. That is going to be increased. There is legislation in place that establishes that it will be increased by a factor over the next 7 years. Each year, it will have an amount greater than $113 that amount will be paid. So you can keep that information in mind and know that that's happening. Now, commercial, as I said before, commercial versus government billing. Commercial payers make no distinctions between an RHC and physician practices. So for the commercial payers, when you speak to them, there may be some that do, but most of the time they don't make the distinction, and you just still bill the services on the 1500 form for professional services. And then you bill all non-Medicare payers and applicable CPT, HCPCS codes, modifiers in the way that you would bill for a physician practice. Now, one of the things I love doing, and you'll see as we talk about it, is I really like talking about the claim form, because, everybody thinks, hey, this is great. We've performed these services, and oh, wait, how are we going to get paid? And it really goes back to the claim form. And what does the claim form look like? And what are some basic things on it? So what I wanted to do is just spend some time and really talk about some charge form components. And as I talk about this, we'll break off and talk about what's specific to an RHC. So in any time you were sending out bills, you have a code set, which would be like the CPT codes. Those are procedures, services, drugs. It's maintained by the AMA. They're the ones who actually establish it, and you bill it out on a 1500 form or the UB04 form. And those are the phrases I use for it. You might actually call the UB04 form like a 1405, but I always refer to it as a UB and a 1500 form. So when we go forward in the conversation, those are the two forms that when I talk about them, how I will reference them. Now, the HCPCS code, that's really interesting. They all start with an alphabetic number, still 5 digits, like a CPT code would be, and it goes on either a 1500 or the UB. And it's maintained by either CMS, or in some instances, Blue Cross Blue Shield maintains their own set of HCPCS codes. Now, the next item that we're going to talk about are revenue codes. Revenue codes actually tell you, they're used, as you can see, as highlighted here on the billing form of the UB, and they explain what the location, provider, type, or procedure is performed. And when thinking about revenue codes, it is a 4-digit code. It's the leading 0 that categorizes the type of service or product that was delivered. And it describes where the service took place. So you know how we were talking before about that it might have been performed, or that it might be at the scene of an accident or something like that. There is a revenue code actually for that. All procedures that are billed on a hospital UB form must be paired with a revenue code. And if the revenue code and procedure code doesn't match up. So if you're putting like a lab test with a radiology revenue code, there's going to be a mismatch there, and they may not get paid. You may get denials back, or most likely you will get denials back. And so you want to make sure that the pairing is correct and it makes sense. Now, I know that there's a lot of words on a page, and if you're like me, you're like, well, just show me some examples, Amy. And so here are typical revenue codes that you would see in a rural health clinic setting. So you're going to see from a range from, and I'm going to just drop the leading zero myself and say, when you look at revenue code from a 300 to a 319, so there are 19 different revenue codes that could characterize laboratory tests. From 320 to 329, diagnostic codes. Other imaging services are typically done between 400 and 409. And then you see like the 521, 522, 524. These are where the actual visits are done to a member, a clinic done for RHC visits. So when we were talking about before, where it's a home visit by an RHC practitioner, it could be revenue code 522. But then going back to the scene of an accident, you would use revenue code 523 to designate that information. If it's done at a SNF unit that's not covered in a Part A stay, you would use a 525. But then if it was an RHC member in a covered Part A stayed SNF unit, then it would use revenue code 524. So these are the typical revenue codes that you are going to see on RHC claims. On that UB form that goes with that RHC claims, you will see these revenue codes. And that's what Medicare uses to help identify that it will be covered under that all-inclusive rate. Now, modifiers. Modifiers are a next one. It's an add-on information that you put with the CPT or HCPCS code that explains some things like location, the component of service, just explaining the service a little bit more. You do use modifiers on both the 1500 form and a UB, and modifiers are maintained by AMA and CMS. Now, with a RHC, you have what's called a qualifying visit. That's the primary service that's being performed at your rural health clinic. And so the primary service is considered a qualifying visit. There is a specific modifier, that's the CG modifier, is required for the line that's considered the qualifying visit. So before, when I said you're going to need a revenue code that says this revenue code is related to a rural health clinic, you will also need that CG modifier. And you report all charges on the service line with the qualifying visit for the CPT code, excluding any preventative services. And you put the preventative services on a separate line. And the reason you put the preventative services on a separate line is because it's beneficial to your Medicare patient. Well, one, it's required by Medicare, but two, it's beneficial to your Medicare patient because your Medicare patient doesn't have to pay a copay or deductible on preventative services, but they will have to pay it for the qualifying visit services. So it allows the system to calculate those preventative services and lowers the amount that your patient will have to pay for the visit to your rural health clinic. So that's for preventative services, and all other services get put on a single line. With this, I just wanted to give you an example of an RHC claim and how it looks. So you can see that the 1500 form, we've got a commercial claim up on the top and a Medicare claim on the bottom. And the commercial claim, the modifier 25 was required to signify that the procedure was a result of this was the result of the visit for the commercial plans. But the CG modifier, when you're submitting that on the UB form, you put the CG modifier and no modifier 25. So you can see that if a patient comes in and they have the same services performed, the 99215, if it is a commercial payment, a commercial payer, you would put the 25 modifier. But if it was a Medicare patient, the 25 modifier goes away. all of the charges are summed up together on a single line, and the CG modifier is added. So then that way you are signifying to the insurance plans that these are the services that are being performed and how they need to reimburse you for that. And then also, oh, that's what I said, and I had a pop-up block that came with it, just summing the dollars together to show for the RHC visit. You leave them separate for the commercial, but on the RHC claim, you need to combine them all in one, and then that remaining line just reflecting that it is a penny, just to show that the services are still there and still being performed. Now, charge code so we've gone through CPT codes, HCPCS codes, revenue codes, modifiers, and now let's talk about ICD diagnosis codes. So these are actually included on both the 1500 form and the UB form. And I know there may be some coders in the room, and I just want to say to you up front, I am not a coder, so please forgive me for some misstatements of some of your common terminologies that you use. But what I wanted to do is just help the non-coders in the room understand the structure of an ICD-10 code. Because if you've been in the business a while, like I have, you know that we used to have ICD-9 codes, and they were little small things. You put them on a claim, boom, be done. But now with the ICD-10 code structure, it's really a more complicated view of the world. And so just explaining that the first 3 digits on the ICD-10 code, it's 7 digits in length. The first 3 codes are a category code. It's rare, very rare, that you're going to only have a 3-digit ICD-10 code that is submitted on a claim or submitted for a service. Most likely, you're going to have a category, and then you're going to have an etiology, anatomic site, or severity included with it. So it shows you that the category and then the etiology, and then you have the 7th character, which is an extension. And that extension shows things like, a fracture of the shoulder and upper arm. So that extension would be the letter A, B, C, D, G, K, P, S, just telling you that. Or it can actually show that you have multiple gestations. So it's showing that that there are multiple gestations, that it could be a 4 is used for the fetus 4, for the 7th character out there. Now, one of the reasons I have, well, not one, yes, one of the reasons I have such respect for people who are coders and are certified coders and do this is because of things like this ICD-10 terminology, that in the ICD-10 terminology, you may see the word but and is interpreted as either and or. So and can mean and or. Includes notes. They immediately appear under the 3-character code title to further define or give examples of the content of the category. So when you're looking at an ICD-10 book, that you may see the information about it, and the includes notes are there. With, when you see the word with in the ICD-10 description, it's associated with or due to. And then when you see the plus sign or a check mark in an ICD-10 manual, you'll know that additional characters are required. There are also additional annotations within the coding for any claims, any healthcare claims that are out there. You may see that brackets are used in tabular lists to enclose synonyms, alternative wording, explanatory phrases, used in the alphabetic index to identify manifestation codes, and the sequence is second. Parentheses are used in both alphabetic index and the tabular index, supplemental words that do not affect the code assignment. And then you have a colon, and the colon is used in tabular list after an incomplete term that needs one or more of the following modifiers. So when thinking about what your coders are doing and the work that they are looking at on a daily basis, and you're like, you're dealing in this stuff, I don't understand what you're doing. That when you look at the manual, that looking at these additional annotations helps them know which of the specific codes should be chosen to be included on that healthcare medical record that is then subsequently used to send off to the billing company. And without ICD-10 coding, claims will not get paid. So it's a very vital service that they provide to your organization, whoever is doing the coding of your claims. So then from there, we also have a type of bill and a place of service. Now, a place of service is very similar to a revenue code, but it is used on the 1500 forms, whereas revenue codes are used on the UB form. And then the type of bill, it's a 4-digit code representing a place of service, type of service, billing stage, and it's used on the UB form. And the leading number is a 0. So when thinking about a type of bill, it serves a similar function as the place of service on a physician bill, except the number provides a separate piece of information. The first digit, it's a leading 0. CMS ignores it. They're giving room to expand. The second digit, this tells the type of facility. The third digit is the type of care. And then the fourth digit is the sequence of the bill, referred to as a frequency code. So sometimes you may get claims back, rejections back or denials back, and they're asking for a frequency code. You know that they're asking about that fourth digit or the third digit, because leading 0 is typically dropped on the claim. Type of bill examples that you may see where you have the first digit is leading 0s ignored by CMS. The second digit is a type of facility. So you can see in some examples over here where an RHC, it's a 7-1X, meaning that it's 7 where they're using the type of facility is a clinic RHC. The type of care is an inpatient or clinic. That's why the number 1 is there. And then the X means it's a frequency code. Was this the admit to discharge an initial claim? It wasn't an adjusted claim. So you know, maybe additional charges have been added to it. And so you have to send out an adjusted claim. So the number would be like a 717. Is it a cancel claim or is it a no payment claim for information only? Typically, what you're going to see for the majority of claims that are sent out are they're going to be a 711, where it's just the initial claim that's sent. And if we lived in a perfect world, we get reimbursed on those claims and we would all be happy. You can also see too that I've shared with you what you would see in a hospital inpatient setting as well as the hospital outpatient setting. Again, going back to this chart where you have that the outpatient, so the leading number is a 1 where it was done in a hospital, but then the differentiator between the outpatient and hospital is that the number 1 is an inpatient and number 3 is an outpatient. And then if you did have an inpatient Part B, you may see a 1-2 and number like that. Skilled nursing facilities, you're going to have as a number 2, inpatient number 1, and then choosing the 4th digit sequence of what the bill is. Going to the next one, talking about place of service. It's used on a 1500 form, and it's a 2-digit code. It is a 2-digit code without a leading 0. And it must match the address and zip entered in the service location. If they don't match, I know that I've worked on many claims where the service location was set up as an inpatient hospital, and yet when the claim went out the door, it went with a place of service of 11, and that causes issues and challenges to be out there. So you can see that an 11 reflects that it was done in an office. 21 reflects that it was done in inpatient hospital. 22 reflects that it was done in an outpatient hospital. Now, I said before, type of bill and place of service are very similar to each other. On a UB form, you're going to use the type of bill of 711 right here. So you can see it's a clinic, RHC, the first bill, 711. This is how it would be reported in the electronic file. It's going in this field, and then if you convert that to a paper image, this is what it would look like. On the 1500 form, you can see that this service was done as a outpatient hospital, and it would be in column B, the place of service. So this one would be in field 4, the 711, place of service being there. Again, the arrows just to point out where that information is. Okay, if that didn't blow your mind, I've got more tips tips and tricks for you. And I'm just going to check because, I'm presenting. Yes, I still have participants on the call. Phew, I haven't lost you yet. All right. So coding tips and tricks. When doing a UB4 form, you want to make sure that you understand that diagnoses are not specific to a single line, but they apply to the entire claim. So you must complete box 70 for reason for visit, and additional diagnosis must be sequenced. Now, I have an example for you as to what this looks like. This is a UB example. And so if you typically have used a 1500 form and never had experience looking at a UB form, you can see that the information is completed here with the type of bill, the value codes, but then the condition codes, that information is loaded here, the reason for the visit, and then the diagnosis codes. And then also including the revenue codes, and that information is listed there. For a 1500 form, which is used to bill all services to the commercial payer, you also report the Medicare Part B technical services and RHC services. And it requires diagnosis codes specific to each line of service. So whereas we think back here when looking at the UB, that the information is just all listed together, it doesn't pull that out specifically looking at it. But when looking at a 1500 form, you can see that the diagnosis codes are listed here, and you put them in order. And with that information that you put in order, they've listed out A through L, or there's actually the A through L that you would put your diagnosis code information in. And then when each of the individual services are listed out, you actually link that service provided to the specific diagnosis code that it's related to. Now, on outpatient diagnosis reporting, you want to report the full diagnosis code to the highest level of specificity for the diagnosis shown to be the reason for the outpatient service. You report symptoms in absence of findings addressed in the provider notes. You don't report suspected, don't report rule out, and the reading physician must always report findings if applicable. And the reason for encounter, the Z codes, you would include a Z code for encounters with no symptoms or findings. Now, I know you're saying, Amy, that's a lot of words. How does this work in real life? Well, here's an example of a patient who's come in and how to use it. So the personal history codes, you want to make sure that they're relevant to the treatment options and relevant for the visit. So example, a patient comes in with a cough. You wouldn't report a history of contraceptive, the Z92.0, but you would report a history of nicotine dependence and a history of tuberculosis. So you can see that they have used the 3-digit code with the period and then the additional information. So it has the category and the information. And then what you will also want to report is support the reason for the screening service. So you want to make sure that it's relevant for the visit and it supports the service. Information that is almost always relevant is a personal history of cancer, malignant neoplasms like leukemia or lymphoma. So patients come in with cough, and you want to make sure that you're including this information. And then also a personal history of falling. And then also family history, risk factors that are relevant to the visit, and any screening services. The things that you want to make sure when you're doing coding, that certain conditions have both an underlying etiology and multiple body system manifestations due to the underlying etiology. So you want to sequence the underlying condition first and the manifestation second. And so then, and then you want to make sure that you use additional codes. 2 codes required to fully describe a single condition that affects multiple body systems. So when thinking about it, that when you sequence these codes and they are doing this information, you sequence the etiology first and then the manifestation. So one comes before the other. So the etiology is the cause and the manifestation is the symptom for it. When looking at non-RHC E&M services, an RHC visit includes medically necessary medical or mental health visits or a qualified preventative health visit. The visit must be in a face-to-face encounter between the patient and an RHC practitioner, during which time one or more RHC services are furnished. January 1st of 2019, virtual communication services are considered RHC services. So if you have distant site telehealth and chronic care visits, they do not require the patient and the provider to be in the same place. So when you are doing distant site services, they are not considered to be RHC services. If it is virtual services, though, that where the communication is um, done are considered to be RHC services. And then transitional care requires that the patient and practitioner visit during the month to satisfy the requirement. Therefore, transitional care is considered an RHC visit. So when looking at this, incident to services, we have what's considered to be the qualifying visit. These items are listed as qualifying visit, except for the distant site visits. But in addition to that, you have incident to services. So incident to services are not considered to be qualifying visits. The charges may be included on the claim with a qualifying visit, but they're going to be separate. And the total amount of these incident to services would be included. And it cannot be billed as a qualifying visit, but it can be included on the cost report. Thinking some more about how we bill for these RHC services, ancillary testing. So ancillary testing, the taking like an x-ray, the taking of the x-ray is considered to be a technical component and not part of an RHC visit. So the taking of the x-ray would be reported separately on the critical access hospitals claim, and then the reading of that would be reported on the reading of it would be included as part of the RHC visit. So when thinking about this way, that separately reported services are read by the physician if not resulted by the servicing provider. EKGs, if the RHC provider reads the EKG, then the reading is considered part of the professional service. The taking can be reported on a separate UB for the provider clinics, and then you report the taking of the EKG on the 1500 form. Now, I know I just said a lot of words, and if you can see, I sort of stumbled over the words there for a minute, but let's actually look at the claims, because that's where it's like, show me the visual piece of it. So in looking at this is a 1500 form, that the taking of the x-ray is a non-RHC service, and you would bill it on the 1500 form and with the TC modifier out there for the technical component only that was being done. And then you would report the RHC visit on the UB as part of that. Now, I've gone through all of those words, but let's really talk about some claim form examples and what this really looks like. And so when thinking about RHC services, when looking at it, we have an RHC qualifying visit where the patient came in with sinusitis, shoulder pain, and an injection. And so these are some CPT codes that would be provided. So you've got the 99213 where you diagnosed the sinusitis, you had the shoulder pain, and then there was an injection of the methylprednisone. When looking at this, you can see that this is an example of the UB form that goes out for the qualifying visit, where you have the revenue code that was related to the services reported. So you can see it's 636 for the medications and the 521 for the office visit. In that initial qualifying visit, you have the CG modifier, and then all of the prices. So these are incident to services that are combined into it. You're reporting them separately, but each of them are priced at a penny, and then the total charges are added up to get the total charge amount in the original line. And so for this service, you would receive one all-inclusive rate payment to cover all 3 lines of service. Now, another type of service is where you have a Medicare wellness visit with a follow-up appointment. So the preventative visit, the subsequent visit is there. You have an alcohol screening, annual depression screening. You have a follow-up for chronic disease management, and a report of onset palpitations. So in thinking about this is where you start separating the claims out, because if you have the wellness visit is done on the 1500 form, where you've got the CG modifier that's attached to the office visit of the 99214, and then you have the annual wellness charges that are pulled out separately and reported as individual dollar amounts. And the reason we did this is because the $190, the $28, and the screening here, because they are preventative services, the patient would not pay a copay for this. So the patient does not have a copay for that, but they would for the item with the CG modifier. And then the ancillary services with the 93000 is reported on the 1500 form. Now, if this was an IPPE where it's the initial visit, then you would report the 93010 down here, and it would separate out. So to just keep that in mind, that for the annual wellness visit, it is included as a qualifying visit. But if it was the initial visit, it would actually count as two services. So now another thing to think about, we talked about the EKGs before, where it was performed in an RHC, the reading was included in the visit, Medicare will pay the all-inclusive rate, and the patient will owe co-insurance based on the charges, provider-based technical. Well, when thinking about that, it's like, how do we separate this out? What does this really look like? How does that coding and that billing work? So when looking at it this way, it's just a different way of thinking about it, that the EKG was performed in a provider-based RHC with a visit. So if it was read by an RHC clinician, the payment is included in the AR, and the technical bill is billed on the critical access hospital's UB. And then Medicare will pay 80% of the all-inclusive rate to the RHC and 80% of the technical component to the critical access hospital. And then the patient will pay 20% of both the all-inclusive rate as well as the technical component. Now, if it was read by a cardiologist, it would still be split to where the technical component would be billed on the critical access hospital UB, and the payment for that technical component would be the patient. But if they were to bill it on a 1500 form, because it was an independent physician, independent clinician, the Medicare would pay 80% of the Medicare professional fee schedule, and the patient pays 20% of the Medicare professional fee schedule. If your hospital is a critical access hospital that has method 2, it would actually pay 80% of the 115% of the fee schedule, and the patient pays the 20%. This is a graph to tell you that, what type of claim form would be used. So if it was read by an RHC clinician, what form they would use with the type of bill, the HCPCS and the modifier, and then the payment and co-insurance. So you can see that there are 3 different things. The technical is always split out, no matter who provides the service. But if it's read by an independent clinician, they bill on a 1500 form. But if it's read by an RHC clinician, the RHC would bill for the services. See, nitty gritty stuff. And I know you're sort of like, okay, Amy, show me a picture again on how this works. So you can see that on the RHC UB form, you've actually listed that information out, and the critical access hospital UB form would have this information if it was the EKG was performed and read by the RHC provider. So yes, you are sending out 2 bills for the same date of service that is being performed, because you are splitting out those technical services. Another example that we can give you is looking at the EKG is performed in our RHC, but it's read by a non-RHC cardiologist. You're actually going to have 3 claims in this example: 1 for the RHC visit, 1 for the technical component, and 1 for the pro fee. So Medicare will pay 80% of the RHC, 80% of the technical, and 80% of the Medicare professional fee schedule. And then the RHC service and the technical component are billed on a UV form, but the physician reading it will bill it on a 1500. So here is an example of, again, the RHC UB and the critical access hospital UB. And then on this example is where the physician bills for those services. Back to one of the statements I made in the beginning where we talk about an RHC clinic visit, commercial versus Medicare. You know, commercial, we're going to want you to follow the commercial rules. Medicare, you would follow the RHC clinic visits. And so when looking at this, that there's a modifier 25 on this commercial insurance, making sure that that information is there. And then in this one, you use the CG modifier for that piece of it. Looking at the RHC point of care, so the services have come in, and an RHC point of care testing where it's a therapeutic injection for contraceptives, and then they also want to have a pregnancy test at the same time. So these are the two services that were provided. An example of this claim, you can see here the CG modifier was left off because no qualifying visit was performed. So you bill it on a 1500 form. Another example of chronic care. So if you have chronic care management where the patient came in and received 2 injections for it, that you see the qualifying visit was billed and the injections are included in this. So in this case, when thinking about this, that the patient, for the services that come in to your rural health clinic, you are paid an all-inclusive rate for the services. So you want to make sure some of the things for when managing your rural health clinic is to make sure that these injections that you're providing, that they're, you know, if you're just a normal low cost injection, what does that look like? What would the reimbursement piece of it be? And should there be some services that you direct to your facility to have performed, because you would be paid based on the cost of those. So just looking at this and thinking about it, and making sure that you are indeed reflecting the services that are being provided and that you are reporting this information on the bills correctly. So with that, I know I ran through that information real quickly, and I will make sure that I get these slides to Laura. Does anybody have any questions for me? I'm going to check to see if I still have any participants out there. I do. Okay, that's an exciting thing too. I do know that rural health clinics, when thinking about the billing, that you may come up with something later, and this is my contact information. Please feel free to reach out to me with any questions you may have. And then I'll also be honest with you, here are some links with some information that CMS has provided, and a lot of different educational activities or educational information, and very helpful. I will say this MLN Matters on rural health clinics, this MLN Matters of 6398, that's a great one. It shares a lot of the information that I have included in my presentation today. And then also, just if you want to get into the nitty gritty as to the provider manuals and how you need to bill for the specific things, those chapters the links to those chapters are in here as well. And then if you're new to the rural health clinic piece of it, understanding what a qualifying visit is, I would recommend just going to this download of what the RHC qualifying visit list. It will tell you all of the services that are considered as part of a qualifying visit for Medicare, that you would be paid that all-inclusive rate when you submit the claims. So Laura, I know that we've gone through this. Does anybody have any questions? I'll take a minute and wait. I'm not hearing any, not seeing any coming through.
Yeah, Amy, this is Laura. I'm not seeing any questions either. That was a lot of really great information. And so, as I mentioned, we did record this and we will be sharing Amy's slides as well. If you get off the call and you're like, hang on, I have a question, please reach out to us. Please let us know. And thank you all for your time. And Amy, thank you for all the great information.